All right, and I'll say some opening remarks as people trickle in. So hello and welcome everyone. Thank you so much for joining us at our first ever AD Summit. We're beyond excited to spend the next 2 days with all of you and would like to say a huge thank you to all of our attendees, all of our presenters, and the Agency for Healthcare Research and Quality for making this happen. We couldn't have done it without all your support. Over the next 2 days, we'll learn from leaders in the field and connect with all of you in the community. We're approaching this event with a deep exploration of patient narratives, and we're prioritizing patient-informed care more than ever before. So we'll talk more about what to expect in just a few moments, but we have a jam-packed event for you. So let's kick off by introducing our team. Bevan, over to you.
All right. Many of you may know us all, so it'll be a refresher. And those of you who are joining us for the first time, here is our fabulous home team. I'm going to turn it over to Dr. Mike Fisher, our founder, and then Dr. Jerry Aborn, our co-founder and the originator of AD, to kick us off with a hello to all of you. So Mike, take it away.
Hello, everyone, and thank you so much for being here. I'm Mike Fisher. I'm the director of NaRCAD. When I'm not doing that, I'm a primary care doctor and the chief of general internal medicine here at Boston Medical Center, our safety net hospital here in Boston. And before that, in years 1 through 11 of NaRCAD's almost 13-year existence, I worked alongside Jerry when we co-founded NaRCAD and got the ball rolling on all this. So I will hand it over to him.
Thank you, Mike, and welcome everybody, and thanks enormously to the NaRCAD team for putting this together. We all know how much effort goes into arranging something this complicated and intense, so I'm grateful to them and also to all of you who have zoomed in for the occasion. This should be a very useful and jam-packed couple of days, and I'm delighted that everybody is here and just very gratified to see how well academic detailing is flourishing around the country and the world thanks to your efforts.
Thanks, Jerry. And as you may see from looking at the participant list, we are cranking up. We're in the 70s right now. 100 people have registered, so it's going to be a juicy day. Here with my co-host, Anna, who kicked us off. I'm Bevan Amira, the deputy director here at NaRCAD. I am in my 9th year at NaRCAD, so as you may surmise, I love all things health detailing, and I'm really excited for you all to get a taste of so many innovative approaches to detailing that folks are sharing at our first AD Summit. Anna, over to you for an official welcome.
Thanks, Bevan. My name is Anna Morgan Barsamian, and I'm the Senior Manager of Training and Education at NaRCAD. I've been with NaRCAD for almost 4 years now. I have a background in nursing and public health, and I am thrilled to jump into this content with all of you over the next 2 days.
Great. Anshul, over to you to wrap us up, our fearless program coordinator who has been at the center of all of this work. Anshul, take it away.
Thanks so much, Bevan. And hi, everyone. My name is Anshul Gupta. I'm the program coordinator at NaRCAD. I've been with the team a little over 2 years now, and you may have received lots of emails from me this week, but really looking forward to kicking off the next 2 days with you all. And if you have any tech issues or need any support along the way, please don't hesitate to reach out. All right, so we'll dive into some housekeeping items before we get started. So if you missed a session at the summit, no worries at all. We'll have the recordings and materials shared, such as slide decks and resources, all available in our new Summit Hub page. So all the recordings and materials will be up on this hub by the end of next week. So please stay tuned for that. And for some additional housekeeping, we love interactivity at our events, so please turn on your videos. That being said, the main sessions here, as you know, will be recorded. So if you do not consent to having your video or photo on these recordings, please keep your video off during the main sessions.
All right, and please use the chat box to ask questions throughout the event. We will do our very, very best to get to every question, either as a verbal response or a response in the chat.
And we also want to make sure we're addressing everyone correctly. So please ensure that your full name is correct on your Zoom window. If you need any assistance, please let me know. And also, if you feel comfortable, please include your pronouns as well.
All right, and we all come from different professional backgrounds, so please remember to spell out acronyms when you're first using them, so we are all on the same page throughout the summit.
And after this event, we want to make sure you're all able to stay connected and be updated on our events and all things detailing. So we'll be adding you to a shared contact list as well as our mailing list. But if you would like to opt out of either, that's totally fine. Just let us know by Friday.
And finally, if any technical issues come up for you over the next 2 days, please direct message Anshul and she will help you out. Bevan, over to you for a little more housekeeping.
All right, so here's what slide's going to come up after any session when we have a quick Q&A. It'll tell you how many minutes we have. We'll do our best to stay on time and not crunch you for time, so you get to ask as many questions as you want. The chat box is our best friend today. We monitor it closely and we try not to miss a beat. So please talk to us, talk to each other. If you want to ask a question that we hang on to in the middle of a session that we'll try to get to at the end, we will keep our eyes on it. So if there is a reason that we cannot get to your question, lots of times folks from sessions do stay on to respond in the chat, and you can also turn to each other. We've also seen folks say, is there a paper on X while we're watching a presentation? And someone in the audience will be like, yeah, I wrote that, or here's where it is. So again, feel free to share as many things as possible with one another. Back to Anshul to show you the program book that she made start to finish.
All right, so we have an e-program book available to you all on our website. Here you can learn more about our presenters, view some more details about session descriptions, and our curated blog articles are particularly on patient experience, patient voices. So I would definitely recommend reading those as well throughout the summit. And I'll pop a link to this in the chat box as well, so you have that.
Okay, and our team at NaRCAD, we have the advantage of having a bird's eye view of all the amazing work going on across our AD community. So we've seen a shift in the topics being covered by AD programs over the years and are continuously impressed with all the innovative work that is being done by all of you. So we're covering some amazing topics over the next 2 days that haven't been covered at previous NaRCAD conferences or events. We'll be learning about the importance of including patient voices in detailing work, understanding and working through stigma that clinicians may have during detailing visits, hosting live interviews with leaders in the field, exploring a detailing campaign on caring for formerly incarcerated patients, incorporating patient inclusivity into our work, excuse me, hearing about a campaign on detailing for sex-positive clinical care, promoting gender-affirming care and detailing work, breaking down clinical silos, highlighting the benefits of community partnerships, and hearing how one detailing campaign helped to redesign care delivery for veterans, and much, much more. So we want this event to be a space where you can create together as much as learn from one another in an interactive way. So buckle up and enjoy the ride. Bevan is going to share about the interactive workshops that we have planned for you over the next 2 days.
And all of these workshops will leave you with something tangible to take away. By tangible, I mean virtually tangible. You can print it out if you really want to hold it in your hands, but want to walk you through our course catalog for day 1. All right, we've got an awesome 101 session about the theory behind behavior change that we're really trying to get down to with our AD visits. So those of you who are newbies, hop on into 101. Unless you're not a newbie and you just want a refresher to dive into theory. 201 is about building the team you want. So let's say you've already gotten through the first couple months or a year of a program, and now you want to reach out, you want to bring in some more detailers, and you want to make sure those detailers are connected. 201 is where you want to go. 301 is a bit of a Sherlock Holmes and Watson approach. You're going to be cracking the case in terms of looking at case studies around going into these visits, having some fingerprints, some clues on how to best approach clinicians versus going in blind. And last of all, please join me for a 401 where we're going to be having some improv and some theater. We're going to be inviting 4 really brilliant expert detailers, and you as audience members get to help control the scenes. I will play a funky doctor, and you will be telling me what curveballs to throw them and see how they handle it. Best of all, you get to steal some phrases that you hear them use that you think are phenomenal and bring them back to your own visits and your own teams. So that is what is going on today there. Anna, back to you to just talk one more time about what we would like to invite folks to do.
Yes, to review, this summit will be focused on high interactivity, hearing from you, the leaders in the field and your creative solutions, tangible skill building, community networking, and peer learning and information exchange. Anchal is going to share exactly what we have in store on the agenda for day 1.
All right, so here's an overview of what's in store for today. We're in the middle of the welcome and kickoff. Then we'll head into our AD fireside chat where we'll hear from Dr. Jerry Aborn and Melissa Christopher, and you'll get to pick their brains on all things detailing. Then we will head into a 30-minute break. And after that, you'll head into one of these 4 program development workshops that Bevan dived into earlier. And all links to these are available in the program book as well as our AD Summit website. Then we'll come back to the main room for another 30-minute break. And we'll hear from the New York Department of Health and Mental Hygiene on their public health detailing campaign on criminal justice. And we'll wrap up for the day by 5 p.m. Eastern.
Thanks so much, Anshul. All right, that's the housekeeping. Now we can get to the good stuff. I'm about to ask you a chat box question, but I'm going to change it on the fly because you have all already told us where you are hailing from in the chat box. So instead, I am going to ask you, where do you wish you were tuning in from? Throw that in the chat box. Don't be shy. If you had all the money in the world, where do you wish you were right now? So go ahead and throw that in. Mykonos, Hawaii, more for Greece, Australia, St. Croix, Nantucket, Italy, Wrigley Field, Geneva, Antarctica, Disneyland, Prague, Lebanon, Florence, a cruise ship in Bermuda, Bali, Mexico, Bahamas, Africa, an elephant sanctuary in Thailand, Venice or Vineyard Haven, Barbados, South Africa. Oh my goodness, so many delightful places. Hawaii, a luxurious water top hut. That sounds like you, Julia Barham. The Caribbean, Mountain Lake, Disney Fantasy cruise ship, and just got back from Greece. We would like to go back with you. Okra Coke, another for Africa, Island of Skye, Barcelona. And Mike says he's happy as a clam in NaRCAD's secret headquarters, which he is now saying is Tahiti, but we all know it's Boston. Sorry to bring us back to reality. Thank you, everyone. Over to you, Anna, for our second chat waterfall to wake folks up.
All right. What is one word you would use to describe AD?
I'm guessing it's not Barcelona or Bahamas.
All right. We have interactive, rewarding, education, innovative, fun, evidence, helpful, conversational, connect, helpful, resources, collaborative, challenge, innovation. Another one for educational. I'm seeing partnerships, challenging, change making is excellent. Supportive, investigative. I like that.
Dignity preserving. I love that one.
Yeah. Vishal says like a box of chocolates, never know what you're going to get. I see a lot of other answers coming in. I'll read 3 more. Focused. I love that one. Impactful and powerful.
Beautiful. All good things. All right. Thank you guys for waking up with us. I am now going to introduce this so awesome session. I have 110% confidence that you will walk away feeling like a sponge or a series of sponges, those of you who are tuning in. So we're going to do this little thing called a fireside chat. I think it'll be a little more exciting than FDR. No, not poking any fun or digs at FDR, but we've got two folks here who just have such an amazing amount of little tasty AD nuggets and expertise and history doing this work. So I'm going to turn it over to Mike to introduce these two fabulous people who are very much in the celeb VIP space in AD, if there ever were one. Over to you, Mike.
Terrific. And this is a really fun place where I get to exercise my prerogative as director and take the fun job of introducing two people who I tremendously admire and respect, and most of all, really like working with, which is such a privilege when you can have that happen. So, so appropriately for an academic detailing conference, I'll start with Jerry Avorn, and he is really, anyone who's doing academic detailing has heard Jerry's name. He came up with the original concept, did the original studies, but didn't stop there and went on to continue doing work that expanded the focus of academic detailing to other areas, got deeply involved with helping various organizations set up their initial programs, including continuing to this day to work on pragmatic frontline academic detailing interventions out in the real world. And it's that combination of the intellectual background that created the field that we're all working on today, with the practical willingness to stay involved with it and do the messy work of figuring out how it goes, that's really so distinctive, in addition to the many other contributions and innovations he's made in his decades-long academic career that are outside the world of academic detailing, but equally impactful there. But even if he had only done the academic detailing work, it would be a tremendously impactful footprint. And so we're really lucky to have him here today. And he's partnered, it's really Melissa Christopher from the VA is a perfect partner, because the VA is one of the organizations that quite early on took up what Jerry and some others had shown in the initial studies and put it into practice in the US's largest integrated health system. And over time, thanks to Melissa's leadership and her relentlessness, her creativity, and her collaborative approach, it's really grown into a program that isn't just big, and it's impressive because of how big it is, but is distinguished by the quality of the work that they do. Many other organizations doing detailing look to the VA's academic detailing service to understand how they can do better, how they can serve the clinicians and patients and communities that we're all working for. And she's been willing to take her program in new directions, expanding their impact, for example, with an increasingly robust research program that's really making important additions to our understanding of how we do this important work. So it's a wonderful combination of the two of them. I will do my best not to hog all the questions, although I have a ton of things I want to ask them, but that's probably why Bevan's moderating. So I'll turn it back over to you, Bevan, to handle the questions in the chat.
Absolutely. All right. Thanks, Mike. And just to say to all of you how this is going to work is I'm going to throw a warm-up question over to both of these lovely folks. Please ask anything you want in the chat box. I will try to get to all of them. We also have a moment where, Jerry, I will throw to you an opportunity for me to pull up a slide about a recent piece that you have written for the Washington Post. Those are the only two plans. Everything else is all up to you guys as my sort of extended radio hosts. So I will start with you, Melissa. Welcome this morning / afternoon. Would love to just throw you a gentle question, which is, what excites you the most about AD and makes you keep returning to this work day after day?
Well, first of all, just thank you for having me. And it's just so humbling to be able to speak with Jerry this morning and to be a partner in this adventure that we've been doing for the last decade in the VA programs. I often say to my team that I have like a voracious appetite for this stuff. So I have to sometimes not eat from the buffet and be a little careful about how many things we get involved with. But I would say the excitement that what is at the heart of academic detailing is this connection that you have with people who are really dealing with challenging issues and how they're willing to work together to improve healthcare delivery because they care about the patient. And I think that that's what drove me into wanting to be involved and expand academic detailing into the VA system. Um, the other aspect of that is just healthcare is always innovating. It's so exciting because research is continually changing how we decide we're going to care for patients, what we provide as that next treatment. And that innovation requires this collaborative partnership. It really makes us think about how we're constantly learning. And learning isn't just about, the absorption of knowledge, but the application of it, because there's so much uncertainty of a study comes out and how does that apply to my patient? My population doesn't look like that study. What does it mean for me as I start to integrate this into my practice? So AD at the heart of that is this opportunity to dance in the uncertainty while holding on to new truth. And I love the opportunity to be able to do that with people because you're literally, I don't know if it's a crowd dancing or it's a tango, but it's definitely this opportunity to engage each other and to learn together and to realize that we don't have all the answers, but the intention is that we're constantly evolving and gathering that to do better for our patients. So I would say
Thank
that's
you so much, Melissa. What a gorgeous kickoff to this. I'm going to throw that same question to Jerry. I also want to say to everybody, we've already got a couple questions coming up in the chat. Please let me know for whom the question is intended. Otherwise, I will throw it to whomever I will just choose and flip a coin. The other piece is, as we're talking, if you have a follow-up question to something that either has said, please don't be shy. Jerry, I'm going to throw you the same question, and especially seeing the arc of all of this that were once seeds just, in your mind. What is most exciting to you, not just about the history and evolution of AD, but also where it is today? So I'm going to give you a double-pronged question.
Okay, great. Thank you. I guess one of the things that is really delightful for me is to be in this just wonderful sandwich that just happened with, on the one hand, we have Mike and the NaRCAD team who have, done such a great job of bringing academic detailing, nationwide and globally. And then Melissa, who, as Bevan said, has done such a heroic job of building what I guess is the largest academic detailing program in the country and showing that it can really become an integral part of a healthcare system, and sort of having both that intro and that predecessor call has just filled my heart with joy that who would have known back in 1983. We just had, I learned from my colleague Leslie Jakowski in Australia, he sent me a kind of an anniversary card last month telling me something I hadn't known, which is May of 2023 was the 40th anniversary of the appearance of our first academic detailing paper in the New England Journal of Medicine. So having that happen last month and having this meeting and all of you present this month is really just a source of enormous joy. I would never have expected when we wrote, well, I guess I had twin expectations. One was that, who knows, this will be just another health services research article in the New England Journal, and they come out every couple of weeks and it doesn't change anything. That was the sort of pessimistic side of me. And the optimistic side of me, which was equally wrong, is, within 5 years, this will be universal across the country and the world, and everybody will be doing it because we've shown that it works, and why would we not? And so the reality has fallen in the middle, but I think things are heading more toward we're on the right track than this is another article that didn't change the world. Bevan, is that an adequate answer, or shall I take another stab?
More than adequate. I would like to throw you what you want to see at Academic Detailing's 50th birthday. If you had your druthers.
All right. Having just turned 75, I'm thinking a lot about anniversaries and birthdays and so forth. So I guess I'll be 85 at that one. I guess I would love to see exactly this, but exponentially more in volume. I think the quality represented at this meeting and at NaRCAD and at the VA program and the programs that all of you are running around the country and the world is about as good as it gets. And I would not worry about making the quality better. I would like the quantity to be greater, in that I would like for the healthcare system to realize that this really is a way of achieving improvements in patient outcome, containing costs often, and helping physicians and other healthcare providers to really feel like professionals again and not burn out so quickly as many of us are doing. So that would be what I would like to see, more of the same on a larger scale, but just like you're doing it now.
Sounds great. I think we can meet that. All right. Well, thanks for kicking us off. I know we have a couple of questions here. The first one that I have is from Trish Ron. Trish, thank you for this question. How do you approach detailer training? I'm going to throw this to Melissa on newer agents when their role and evidence is still evolving. And I think that's a question many of us have. And also the second part of that question is, how do you keep detailers up to date when that clinical evidence is just, the experience is just changing over time so rapidly? So that's over to you.
So our training has changed a lot in the last 10 years, and I'm want to put a shout out to Dana Wells and Sarah Popish and Julie Hemstreet, many of the folks that work in the VA program. So we started, working on the advanced skills is kind of what we term these programming kickoffs for a lot of our campaigns. And I think with new medications that come out, particularly in the VA system, we have the benefit of really developing kind of place and therapy types of opportunities to digest that evidence and to implement guidance for our prescribers. So a lot of that is available publicly. So if folks don't take advantage of that, I would love you to go to the VA's public site. We have a lot of really great recommendation documents that walk through that evidence and synthesize that evidence. I think that acknowledging the uncertainty about developing new products and surveillancing the safety of them is a critical part. So the advantage I think our integrated system has is we do a lot of surveillance. We aren't assuming that everything that comes to market will not have new information that presents about potential signals and safety concerns. And I think being able to have that conversation very openly with our providers is important. So we train for that in our detailing sessions. A lot of that is like in the simulations that we do in advanced skills training. A lot of it is also talked about. We have a few new programs we call, thanks to Dana and Sarah, we have something called an AD Chit Chat. And that allows detailers to get together in community and to work through some of these questions that are coming up about new products that have been released and their place in therapy, even other concerns that providers are raising, concerns that are coming up about the decisions and lack of information in certain areas. So I think the benefits of training is that you can't just do a one-time flood of information and assume that that will be adequate, because it is an evolution of content. And so creating intentional opportunities to really knowledge share within your organization, I think is a critical investment. So we are doing that. We have a program called the Joint Education Detailing Instructors. They're Jedis. I don't know if anybody likes Star Wars out there, but we do. And that is like our master Jedi groups. Those are the experienced detailers who have been working for many years in our program. They're there to help mentor, provide training, and to really navigate a lot of these amazing issues that come up in healthcare. The technical side of things, I am grateful that the VA has a lot of resources for developing guidance on new products that come to market and how we really position those in therapy. But we also leverage, external sources when the VA doesn't have that developed too. So I think you have to balance that, because that is free information to the public. So our providers are seeing that same information when things get published So I think we have to be looking at not only internal recommendations, but also what other organizations are saying and why. So that would be, I hope I answered that question. We do, campaign advanced skills, but we have touch points on a monthly basis that open up opportunities to be able to navigate through those more challenging issues that are coming up with uncertainty around the evidence.
Thank you so much, Melissa. And I think, that's something that a lot of folks need ideas about versus thinking, I got to go back to the drawing board and look at a whole nother slew of evidence and change my detailing aids and change my entire approach. The more that you can do that on a frequent basis or a regular basis, as well as I love this idea of it being a team connection space, a space that rather than a trickle down of more information to incorporate, it's a looking laterally. How do you think we should do this? So that's lovely. I have a big question here from Jackie Travers in Oklahoma City, who has been detailing on pediatric detailing for folks on Medicaid, very tricky topics, and is a one-woman show, quite a mighty one at that. Her question I'm going to throw to Jerry. How do you think we in the US could have a more integrated and cohesive AD system, more like the VA or the provincial programs in Canada? She says, we've got a great patchwork going, but how can we be more unified and consistent? So Jerry, what comes to mind?
Okay. I think sharing materials is a great way to do that so that we don't all have to reinvent the wheel. We are all big fans of the VA materials, and I saw Elizabeth Mock just put a little smiley face in praising the VA materials. At Alosa Health, we put all of our stuff up online for anybody doing academic detailing to use in any kind of non-commercial way they want, and not having to necessarily create everything from square one, especially when there's, and I know a lot of the other programs that are on the call also have great materials of their own. So in terms of that, as well as the kind of training approach, which NaRCAD has done such a great job of sort of putting out there. The nice thing about the way that pretty much all of us approach academic detailing is that it is a public interest activity. And as far as I can tell, nobody is trying to get rich by doing it or set up a mega corporation to rival Microsoft. We just want to have good stuff out there. But I think we still have, as a field, further to go in being able to actually take advantage of, with giving full attribution, of course, to the existing materials, so that everybody can really benefit from all the hard work that's happening in so many centers around the country and around the world to get on top of this. But Bevan, if I may, I'd like to also take a stab at Trish's first question, which is how to handle issues that come up about new products. And if you've got a copy of that slide, maybe this would be a good time to throw it up there.
Keep it talking and I'll bring it up.
I have become, as have others on the call, particularly from Alosa, Ellen Dansell, Tony DeMello, Ellie Grossman. We are working together with Paul Finicos and many others at Alosa in trying to come up with an evidence-based, even-handed, patient-friendly response about what in the world to do with the new Alzheimer's drug, lecanemab, or Leqembi as it is branded, which will be almost certainly given final approval by the FDA in the coming 2 weeks or so. And last week I had this piece in the Washington Post that Bevan was good enough to put up there. If you have trouble accessing it because of a paywall, just send an email either to Bevan or to me at javorn@alosahealth.org. And we'd be happy to make it available to you. This, it seems to me, is a wonderful challenge / opportunity for academic detailing literally this month and in the coming 6 to 12 months. We've got a drug that works not very well, poses the risk of pretty awful side effects. Patient burden is a very big deal in that, who among us has taken care of a frail elderly person that you would like the chance to take them in every other week for an IV infusion for months or years at a time, not to mention the possibility that the drug might blow their brains out for them. And what is being heard in the media and even in the medical literature is this is a great, this is a drug that really is the first thing to help Alzheimer's. And what we're trying to do, and within, I would say, 3 weeks, there'll be something at the Alosa Health website, which you're all welcome to take and use out there, We're also hoping to make available other kinds of things like video grand rounds and academic detailer training. Again, totally not for profit. We just don't want to lose a ton of money on it. About how to use academic detailing to deal with the onslaught of patients thinking this is going to fix grandma's Alzheimer's, when, as we all should know, at best, all it will do is make grandma's deterioration happen a little slower, with the risk of maybe blowing her brains out and having every other week visits to the doctor, and perhaps costing the country $2 to $5 billion a year. And so we're about to launch not a get mean with Leqembi, but really a evidence-based statement that says essentially, well, it doesn't not work, but you really need to have an informed clinician and family and patient to think about what risk do I want to incur for what very small benefit. So I floated that out there a couple of days ago in the Washington Post, and we will be putting up on our site within a month or so materials which we welcome you all to use nationally. And if we can put together additional things like a video grand rounds for you to give to your local hospital or physician practices, we'd be happy to provide that.
Thanks, Jerry. Appreciate that. All right, so want to go back to a great question from our colleague Elizabeth Mock, who is hailing from up in Maine. Elizabeth, unless you are somewhere else in the country at the moment. All right, she's in Maine. So here's her question. You may all know the phrasing, if you build it, they will come. Elizabeth's saying, we have built it, but they have not come. How to engage prescribers who are burnt out and overwhelmed with commitments? This is a question for the ages. We get this all the time. It might even be the most asked question. How do you get them to go to voluntary sessions? What's a best practice for making connections in an age or a system where we kind of don't go door to door as much anymore? Let's have some quick answers, some nuggets from both of you. Melissa, I know you have a very structured system that a lot of public health departments don't have. Would you be able to look through the lens for a moment of some programs that don't have a great budget or a lot of folks on staff, and just offer them a couple nuggets that you think would help from a relationship building perspective?
Yeah, I think the pandemic kind of put us in a situation to think outside the box of how not going door to door, our traditional techniques had to be explored. So I think in many ways we were targeting new provider types. We were looking at virtual visits and how to get connected to support staff instead of the provider because they were too busy and overwhelmed. There was a lot of creative things done, I think, to try to think about what the provider's immediate needs were. So what could we do to address the immediate needs, and maybe put any agenda we had aside so that we could have more of a service model, if that makes sense. So maybe that's why we ended up with 65 campaigns topics. So I will say that there's downsides to that. I don't want to say that there's not downsides to it, but because I call that dabbling in detailing, you're not sure exactly what you're getting for that. But I think that's the customer service issue. If you don't have a service, so we call ourselves the academic detailing service, if we're not serving anyone, then we're not developing a real relationship or value to that individual. So in thinking about service, I think you have to really understand your customers' needs. And they were changing during the last 3 years. There were different challenges. So, COVID came in and we picked that up as a campaign to help people think about what they were going to do to help talk about vaccine hesitancy. There was lots of adaptations. We got a new electronic health care record in a few of our VAs. So guess what? The detailers did Cerner discussions with providers because they were pulling their hair out trying to figure out this new electronic healthcare record. I mean, that's not a typical academic detailing topic. Why would you be doing a EHR discussion? So I think it is about being flexible to your customers and recognizing that they have needs that you may not think are yours to meet. But if you want to get your foot in the door and you want to have that next appointment, then I think you consider how can you help them where they're at and what can you do to make that better.
I love this, Melissa. And Jerry, I'm going to just as an aside tell you that I'm going to throw you a different question in a moment. So be prepared. Melissa, one thing that just struck me is you use the word customers. That's such an interesting approach because that really ties in with the word service. And so what I'm hearing you say over the past minute or two is if you meet the need that they have overall, like sort of a broader needs assessment of what's important to them, whether it's how to use a tool that's not working, whether it's, hey, this topic has become front and center. If it's more of a, hey, it's voluntary and it could be about something that's less relevant to you, you're not meeting a demand. But if you're able to suss out what those top priorities are, you're more likely to be either invited in or at least have interest peaked in those areas. So I think that's a really nice way to think about what's important to folks, and then pairing that with gaining access from a pragmatic perspective. I'm proud to say that we have a lot of tools on our website about how do you send an email someone's going to click a link on, little things like that. Why are we getting away from mailing things that we think might just sit in someone's office and collect dust? So if we can pair those two things, I think we'll have some success. Thank you, Melissa. Jerry, got a really cool question from Jess Allard, one of our facilitators who is up in New Hampshire. She says, I have a son in medical school. What do you want his professors to tell him and other future doctors about AD? What a cool question.
In brief, I would say the most important thing that any medical school faculty can teach any medical student is not about receptors or genetics or molecular biology, but it's about how to think about the evidence. And I've bemoaned this ever since I started at Harvard Medical School in 1969. And they tried to cram our heads full of facts, but not about how to think critically about, is it real? Is it true? Does it matter to my patients? And I think what I would love to see communicated is the idea that academic detailing is a way to get help in thinking about the evidence. Because, you've all heard the old joke that they tell the first-year medical students, half of what we teach you is going to turn out to be wrong in 10 years. We just don't know which half. I would say maybe more like 2/3 is wrong. But what is never wrong and what is enduring is the ability to think clearly about where did this knowledge come from? How is it derived? Did they get it right? And how do I apply this to benefit my patients? And I would love to have folks understand that what we're doing in academic detailing is trying to help doctors work through the evidence, because we're not anti-drug, pro-drug, in favor of this or that approach. We're just pro-evidence, and thinking about that and knowing how to access that help is probably something that every medical student should hear about.
Love it, Jerry. Thank you so much. All right, we got a couple more juicy ones here that I'm excited to share. And thank you, Anshul, for dropping so many gems of nuggets and links in the chat box. We'll make sure you have a complete list of that by the end of the summit tomorrow. So don't worry if you missed a link, we'll make sure that you have it. Great question from Nate Rickles, former presenter of ours from the University of Connecticut. I'm going to throw this both to you and maybe choose one answer and a reason why you think that is. Is there a clinical topic that it's just not well suited for AD? What's something that you feel like, yikes, this would be a tough topic to do with AD? And maybe from your own experiences. So Melissa, I'm going to turn it to you first, if you don't mind my, throwing you the mic without much prep.
Well, Jerry taught me, I think the first year I started doing academic detailing, I had they wanted us to work in a mental health area, and we had a product that was very underutilized for schizophrenia. And so we were working on the clozapine expansion efforts for our mental health providers. And I think, halfway through starting this project, I started realizing I was just hitting lot of barriers. And Jerry kind of said, well, I'm not sure that AD is the right solution for this particular campaign. I don't know that this is a knowledge problem. It sounds like there's some system things going on that you have to think about and consider, the impact of that. So I would say that AD had a role at some point to help that topic, but it wasn't probably the primary intervention that needed to happen in order to improve the prescriber's ability to uptake that treatment into their evidence toolkit. So I think that's one thing over time that I think there's a lot of complexities. There's different levels of complexities with areas where we're trying to change practice. And I think maybe it's a situation of when would AD be appropriate, not if AD is appropriate. There can be a real timing issue there. What you don't want to do is create this dissatisfaction with providers where you give them the knowledge to implement the evidence, but then they're just hitting one barrier after another and they can't really act on that. I think that, I would use this phrase, like, how do we make the system as smooth as butter so that the provider can come in and take that knowledge and apply it in their practice without all these complications or stops that happen to them. And so I think that's important when you're assessing the timing of AD, as well as whether it is the intervention you really need to be starting off with.
Lovely. Thank you, Melissa. And one thing I want to say before we transition to Jerry's answer is something we've noticed, and a reason why we've really geared today and tomorrow's programs toward these challenging topics, more challenging topics, is think about the types of behavior change that are hard to measure, right? Looking at some more qualitative data versus, hey, we can clearly see this change in prescribing or this use of a new tool. So I would add that as well, that folks that are trying to do things that are that surround, social determinants of health. I know here at NaRCAD, we've been starting to think, could we do a study that measures stigma within these visits? And so things like that may also be tricky when there are new ways to approach things that maybe some of us haven't figured out yet. So wanted to throw that in, even though I am not FDR in this situation. Jerry, over to you. What's a topic that you think would just be really tricky when paired with AD?
Bevan, let me turn it around and refer back to that conversation that Melissa mentioned, because I think I've maybe broadened my view a bit since that first conversation, probably prompted by some stuff that Mike was working on while he was in our division about practice facilitation. And that is, might we think about an aspect of academic detailing that would be bringing the evidence not just to the clinician who may be hamstrung by the system in which we work, but maybe to the decision makers at the system level, so that they can be educated about the evidence so as to remove the barriers that they are hurling in front of the doctors to make their care less evidence-based. So yeah, it may not be something you can address in the office, but it may be something where if we were to do academic detailing of the P&T committee or the MBAs who are running everything and try to, sorry, any MBAs on the call, but to try to use the evidence base to bring it to those folks if we have a problem where the practitioner can know everything. There's that great quote from Upton Sinclair from about 100 years ago that it's difficult to get someone to learn something if their salary depends on their not learning it. So maybe moving it up a notch to, or down a notch to the people who are making the rules would be maybe my 2023 answer to the clozapine problem.
All right. Thank you, Jerry. And as always, please feel free to turn these questions on their heads. Very important. All right, we have a question from Julia Barham up in Canada. I'm going to throw this to both of you and ask for you to just speak from your gut. Give us a little bit of a reason why, if you like. She says, if you could study or research any aspect of AD today, what's one research question you would want to have the answer to? I'm going to give you a second to think about that. But what kind of seems like, oh, if I had all the money in the world, people ready to go, what's a question I want the answer to? Melissa, I'm going to throw it to you. And within any topic, within any approach, beyond the VA, whatever you think.
Well, looking at a national system, I think we're constantly asking about the dose effect of academic detailing. I think a lot of times people assume that once you give the literature and you provide that information, that it's like a one and done sort of thing. And I think there's very complex changes that are happening in practice change. And I wish I had a calculator that could look at the complexity of a behavior change and spit out a dose that you need as far as how many visits or how much time commitment. I think it's just it's individualized to the clinician. And I find that in a large system, how do you control for that? So asking the question, how potent is academic detailing, and how many other multifaceted interventions? So one of the things Jerry brought up was practice facilitation as another strategy. We use things like audit and feedback and provide data with population health tools so that there's specific information that the clinician can act on. So it's kind of looking at this complexity factor, and how do we study the complexity of the behavior change while understanding the effect of the solution. So what does that solution really have to entail? What are the components, and what is the dose that you need to use to be effective? So that it's a question we haven't answered yet, but I put on Mark's plate all the time. So I'm like, I need the dose effect of this.
And Mark is Melissa's colleague, who is one of the most data savvy folks that I know I've ever met. So thank you for that. Jerry, if you had to pick one question to answer, let us know. And everyone in the audience, I'm about to ask you the same thing to type in the chat box. If you wanted the answer to one question, it could be clinical topic specific, it can be anything that you could research, what would it be?
I would say, what are the attributes of academic detailing visits that are most powerful in improving patient care and clinical decision-making? And, the study I can imagine would be bazillion visits that are recorded, and having a psychologist and a sociologist and an anthropologist review the transcripts. And, of course, the budget would be infinite. And then looking at the behavior change that occurred or didn't occur after it, and what is it? The interactivity? Is it the presentation of the data? Is it the visual materials? What is sort of the secret sauce that really makes it work? And that way, if we knew what pieces of the intervention were the most important, we could do more of that, and maybe do a little bit less of some of the other stuff that may not be the most effective.
Love it. Thanks, Jerry. And thank you to those of you in the audience who have added their own pie in the sky questions to focus on. Zach from Canada says, my one research question wish is group visits versus one-on-one benefits versus risk, perceived barriers and roadblocks to embrace evidence, how to get AD visits to the clinicians who need them the most, i.e. beyond the keen early adopters. So really loving that. In the meantime, someone had a question of, what is a name besides academic detailing? And, all respect to you, Jerry. People are saying and have said, it's not the sexiest name. It's not the most intuitive name. When I type it in LinkedIn, I get textbooks for college as well as car detailing shops. How do I handle this? And we all here at NaRCAD have strongly encouraged folks not to walk in and say, hey, I'm Bevan Amira, I'm an academic detailer. Whoa, what's that? It takes 5 minutes to kind of get people level set. So some folks are sharing in the audience what they use. Michelle Dresser from the New York City Department of Health and Mental Hygiene says that her team uses the words outreach representatives. Elizabeth from Maine says coaching is a word that they try to use. Tony, who is the one who asked the original question from our sister team over at Alosa Health, said, maybe a title like medical science consultant. Other folks are adding things now. So what I would ask is, if you could sort of rebrand and see if there was a way to unify this term so that we can have global domination, what is a term that you think would work? And Jerry, you are very much free to reject this question and hang on to what you originally created. But Jerry, I'm going to ask you to answer that first.
Well, years after I gave it the name academic detailing, people began to say, well, it's a great name except for the first and the second words in it. Academic, because that becomes kind of a pejorative term of being kind of irrelevant and ivory tower, like, oh, that's just so academic. And detailing, because it was a way of associating ourselves with the pharmaceutical industry, which is the opposite of what we want to do, not to mention the car wash issue. So yeah, there are problems with both the first and the second word. On the other hand, it has kind of caught on, and a lot of people, thanks to the efforts of folks on the call, have brought it to the public's awareness. So I think it's less important what we call it than what we do, but for better or worse, it's it's a name that has gotten some traction globally.
How about you?
Well, this question comes up pretty much every year at our strategic planning with our advisory board, where someone always asks, "Can we rebrand this term?" I think last year they decided to, because we're in a military environment with the veterans, they wanted to term it as special forces, that we're basically the special forces for the VA. We're boots on the ground that go in and solve the most difficult, complex, healthcare problems. I would agree that, it sometimes is not quickly understood in an introduction. And I think the further we are from pharmaceutical industry having direct access to our clinicians, that relationship that used to be very common is now in many cases not something people invest in anymore. So I think we've modeled it after a lot of the work that they have done in some of our relationship building. But I do think that in many ways we're advocates for providers and for patients. We're working towards, really trying to find the best outcome for the population we're serving. So I do like some of these suggestions, like outreach educator, or, I think, I believe Kaiser might call them drug education coordinators. There's different terminology, and I guess it really depends on, in many ways, the topics you're covering. Some of our public health programs, I'm sure the public health detailing makes sense because it's, it may be about screening and not really have anything to do with pharmaceuticals. So I think that having flexibility in your branding is probably important in order to really reach your customers.
I was just about to say, I think our next research proposal to ARC will be to have a global branding summit, make sure everything is translatable to our group in the Netherlands as well. A couple more things here: health education specialists, health collaborators. We all know the original term evidence ambassadors. Lots of just really cool ideas here that I'm excited that you all are chatting with each other. Health advocator, provider outreach specialist. Good stuff. And I'm seeing so much great back and forth in the chat. Please all take a moment to scroll, especially when we have our juicy break in about a half an hour. Trying to keep up with all these great questions. One thing I would love to ask, and thank you again to folks who are responding to the questions about team meetings. Lots of great ideas there as well. I have a question from our colleague, Lauren Regier. He says, the discussion around customer and service raises potential considerations around perceived needs versus unrecognized needs. How should one approach situations where the important needs are not well recognized or acknowledged? I'm going to guess taking a pretty layered needs assessment approach could be a way. But Melissa, what are some thoughts on that?
I think that's where we approach things more as an awareness campaign. And when we're socializing content with providers. So I think that the strategy may be a little broader strokes, because a lot of times we are not singling individuals out. We want to really develop that rapport and that trust. And I think, meeting the needs that they identify as priority is critical in this current culture of healthcare. They don't have time for anything else, right? I mean, there's just time is the currency that we're dealing with. But I do recognize that many times there are unseen concerns. And I think an area that we're really moving into is like health equity, right? What you can't see, what you don't what isn't being done if you don't make some of those things visible. And VA has done a really great job of creating resources that show where there's gaps in delivery of healthcare for populations that were really trying to close that gap. And I think a lot of times providers have no idea, they can't see that that's not happening. So that awareness factor from a needs perspective, I think becomes trying to create more social discussions and global awareness. And then I think it opens the door to make that individual conversation happen. But I think you have to really be strategic in how we create that awareness so that there's not, again, that concern that we're imposing our own agenda on the clinician. And we're really trying to partner with them about things that they may not be aware of.
Thanks, Melissa. Lots of great thoughts and some silliness in the chat. Do not miss the silly. That is a big part of our brand. One thing Milena brings up that I think is really interesting is the certification piece. So she says that she is CHES certified, which is Certified Health Education Specialist. So to say health education specialist could also be confusing and imply that there are licensures that actually aren't there. I know here at NaRCAD, we've been talking about, should we explore an official licensure approach? Those are all things that are still up in the air. I believe I've gotten to most questions. I'm scrolling to make sure I haven't missed anything. In the meantime, Mike, I know you have quite a few up your sleeve. Let's pick a fun one if you have a fun one, maybe up your sleeve.
I have absolutely. I have my version of this one in my notes was AI, do you welcome our new robot overlords? But let me actually ask the more elaborated version of the question, which actually is a serious one, although it's fun to make a lot of jokes about AI these days. And to Jerry's point about two words, is it either artificial and certainly is it intelligent, or both open questions. But there's the underlying principle of AD is it's increased. It was, even when Jerry did the original studies 40 years ago, and more so now, incredibly difficult to keep up with all the evidence. At its best, things like AI, may be very sophisticated and sort of teachable search engines that can, maybe do some searching on things. So I actually, all AI jokes aside, although you're welcome to add AI jokes if you want to, I'm curious how you think about that, or other new technologies that might either provide new opportunities in AD, that might allow detailers to be impactful in different ways, or allow us to meet that challenge that came up in one of the first questions of dealing with rapidly changing evidence. So from what we've seen so far, do you envision practical or useful applications of this, all the sort of the jokes that AI lends itself to aside?
Which of us should answer that one first?
Why don't you go ahead, Jerry?
Okay.
I suspect you've seen both the overhype and the both the messianic and the doom and gloom overhype of AI, and hopefully have a somewhat more nuanced view yourself.
Right. Well, yeah, I don't know about whether it'll cause extinction of the human race or not, but I have thought a lot about it in relation to the work that we all do. And I think, in all seriousness, we may be among the last knowledge workers standing once all of the lawyers and accountants and business executives have been replaced by ChatGPT. And the reason I say that, in all seriousness, is that I think what we do, when I think about what we all do at ALOSA or in the division of pharmacoepi over at the Brigham and Harvard Med School, in really tearing apart the evidence and looking at it and saying, well, it looks like that study showed the drug worked, but they didn't have a good control group, or it looked like it didn't work, but they enrolled the wrong population. Those are nuances that, yeah, maybe in 5 or 10 years, AI will be able to do, but I don't see that coming down the road very soon. I think that the two aspects of what we do in academic detailing, I think, are really going to transcend the limits of AI in at least the next couple of years. One is really thinking hard about the methodology that lies behind the evidence to know whether to believe it or not. And then second is the personal interactivity that maybe a bot could simulate. But, I think we all can pretty much tell when we're having a bot simulate interactivity with us. But they're really, getting inside a doctor's head and saying, why are you prescribing that? And how does it make you feel when somebody comes in and, has a problem with opioid use disorder or alcoholism or whatever? Those are things which are, for the moment, beyond the grasp of the current generation of artificial intelligence. And, I think of this story that you've probably all read about, a lawyer who tried to get this is a true story, tried to get ChatGPT to write a brief for him on a case, and it came out with this very eloquent, glib thing with citations to prior cases and making the argument of why it is that his client should win. And a lot of the material was made up. And then to check it, he went back to ChatGPT and said, are all these real cases? And ChatGPT said, yes, they are. And he was in a lot of trouble because no, they weren't. The bot just hallucinated or confabulated them. So I think we're on solid ground because what we bring to the table is both so rigorous and insightful in terms of evidence and so empathic and interactive in relation to dealing with other people.
Thanks, Jerry. I'm going to grab the mic away, Melissa, just so we have time for a couple other ones, unless you guys, we can have a summit on AI and AD sometime in the future. So thanks, Mike, for that interesting question. Again, folks, check out responses, and Anna is keeping me on track for 2 questions I have missed. Vishal, who is one of our academic detailing expert facilitators who hails from Detroit. Vishal had a great question that I am pulling back up at the moment. And Vishal, you know what? I'm just going to unmute you, if you don't mind, to talk about what do you see as the biggest challenge the field of detailing will have as we go forward and further develop the field? Vishal, what's something you think it might be? Just to ask, what's something that, I'm not going to say worries you, but that you see coming down the pipeline. And maybe what we can do is ask Jerry and Melissa not only to add to that, but to maybe come up with some on-the-fly solutions. So Vishal, over to you.
Absolutely. Thank you. I think one thing that I've sort of thought about is just the sort of the figurative rolling with the punches, if you will, not in the sake of actually, doing a detailing session, but sort of how do you continue evolving as the field evolves, as the science evolves, making sure we're not only keeping up with it, but even potentially trying to get one step ahead and being, as for example, going back to the AI conversation, how do we stay ahead of that? What are, some challenges that we would want to sort of look into trying to to predict or almost trying to prepare for as we go forward and learn more about the science, learn more about further medical conditions that we may be able to provide detailing for.
Melissa, you want to take the first crack?
Yeah, I guess I was kind of thinking about the aspect of staying present with it's both the challenge of staying present with the challenges that our providers are currently facing, while also anticipating what's coming in the future. Healthcare has some definite transformation that we're undergoing, and the shortage of providers is one of my biggest concerns on my mind. So I think while I sometimes think technology could help with that, because the mundane tasks that some things are being put onto our providers' plates that could maybe technology do in place of them having to do. I think there are times where I would love to see innovation and technology replace the not low value tasks that clinicians are being burdened with because of whether that's insurance requirements or whatever the documentation requirements. If AI could take everything in your head and put it into your note easily and quickly, it would be great, right? So the expediting of technology to support our workforce depletion. I also feel like the other thing that has really been on my mind lately is just joy in what people do in healthcare is a real threat that we are losing that connection of being a caring population, a population of healers And I feel like, while technology continues to evolve and new information becomes available, that personal touch that people experience in a healthcare setting and the advocacy that those healers have for an individual's well-being and whole person, that connection, I think, has been lost to a degree in the way that our healthcare system is evolving, and the taxes of shortages and resources that are really not available in a team-based environment anymore. So I think some of the things I worry about is that we have some fundamental things to consider infrastructure wise, of how we go forward and create solutions to, how do we bring belonging back to healthcare? How do we bring joy back? How do we have play in the workplace? These are things that allow people to be resilient and to thrive. And we lost some of that. And, the excitement of teaching, the excitement of sharing knowledge. When your shortages are so impactful and you care so much about caring for people and you want them to be able to get care, you don't have any space or time for the other things that make you human. And so I do think that component is something that's been on my mind. And how do we change that? What are our strategies that can be effective to change that?
My thoughts on that are strikingly similar to Melissa's, even though we didn't coordinate in advance. But I'm reminded by her, and by the way, it is so wonderful to hear somebody talk about humanism and joy and play and feeling, like a giving caregiver, that we hear so little of that in medicine these days. A number of years ago, Atul Gawande had me come over and give a talk to his group about academic detailing. And when I finished, one of the questions was it wasn't even a question, it was sort of a challenge / put down from a medical informatics person. This is before anybody really thought about, AI in this way that we're discussing. And he said, this is all very nice, but you could accomplish all of that much cheaper and more efficiently at scale by just having drop-down menus. And every time a doctor goes to prescribe something, he or she is given a drop-down menu and tells them if they got it wrong or what they ought to be prescribing. And, that is a very common view. Usually it's not said quite so crudely, but I think that speaks to what Melissa just said. There is, and people don't always see the connection, this tremendous problem of burnout in healthcare. And, you periodically read things about some huge proportion of doctors, nurses, et cetera, are planning on leaving the field in the next 5 years because I think in part, besides the long hours and, for primary care doctors, not such great pay and awesome, unbearable responsibilities, is this over automation and the mentality of there's just a drop-down menu for that. And I think what we bring to the engagement is, first of all, respecting the docs or other prescribers that we talk to with the idea of saying, making a prescribing decision is actually complicated enough that we're not going to demean you by saying that all you need is a drop-down menu. And the other thing that I think people get from an academic detailing encounter with a respectful colleague that they can also respect is this is an opportunity to learn something, to get more professional rather than less professional, and to deal with this big problem of burnout that every place you turn, there's a fucking drop-down menu telling you what you're not allowed to do. And I think that puts the two pieces of what Melissa was saying really, together as she did, that it does both. It makes this a more human activity on both sides. And it frankly, you taught somebody something instead of just saying, no, you can't use that, you got to use this, which is a great way to burn people out.
Thank you, Jerry. Yeah, I'm really glad the conversation has, taken this kind of turn. So thank you for that question, Vishal, and for those answers, Melissa and Jerry. I wanted to respond to Jane Luby, who in the chat says, one doctor said to me this week that this information was refreshing because everyone always only wants something from her. So that's a very human piece there too. Someone comes and knocking, they want something. And so to be able to empathize with those burnt out clinicians, to know how many people come to them with need. And, what we've been talking about here at NaRCAD for the past 5 or so years is how do we also go in not just as ambassadors of the evidence as detailers, but ambassadors of empathy? How do we go in really trying to remember that our agenda, and when I say our, I'm not a detail like all of you, but trying to use we language, that our agenda does not have to be, okay, get through key message 1 and 2, get the buy-in, get out. It's also, we talk during our trainings about that it's a win if that person just feels seen by you and wants you to come back. So thinking about what I hate being called soft skills, right? Like this idea that they're not as important, but they are, if anything, the most important part, I think, of being a good detailer is you can come in with clinical expertise, up the gazoo, but if you don't have that sense of how to meet a clinician truly where they're at, that would be quite difficult. Couple more questions and reflections here in the audience, especially about things like AI and just talking about challenges and passion. I have a question for you both. So the more that we are seeing healthcare not just use social determinants of health as buzzwords, intersectionality as buzzwords, but really trying to find a way to not just look through those concepts as a temporary lens, but really incorporate our research and our approaches through that lens all of the time, which of course has its own challenges in a healthcare system that has a lot of foundational and structural challenges and issues. What would either of you say with regards to looking at academic detailing from a perspective of the neediest of patients, the most underserved of patients? Jerry, I know that your background and expertise is in, gerontology and really looking at what do older folks need that they're not receiving. And really, I'm assuming thinking about folks who can't advocate for themselves as well, particularly being in care facilities where perhaps they are having, there's polypharmacy and they're less lucid and things like that. And of course, Melissa, we know that not only are you working with the veteran population, you're also looking at the cross section with homelessness, folks who use drugs, PTSD, suicidality, all of those different pieces. So my question is, do you see AD being able to look at patient populations and their intersectionalities and their diverse extreme needs? Do you see AD as being a tool that can really make an impact for those patients who have so many co-occurring issues? I'm going to start with Jerry and then I'll throw it over to you, Melissa.
No, I don't. And let me explain that apparently crude answer. I think we got to focus our energy on what, at least in academic detailing, on what we are good at and can accomplish, and not try to dilute our efforts in ways that we are going to be, at least in the academic detailing role, basically impotent. I think we should, as humans and as citizens, work as hard as we can to do whatever we can to end the grotesque inequality of income and access to care and the hideous racism and sexism that permeate all of American society. That's awful, and as individuals, we should do it. I'm less clear what we can do as academic detailers to fix that, with one exception that maybe is worth mentioning, and that is helping doctors at least to understand that a patient's problem with getting the right medication may be about affordability, which in turn tracks back to economic inequality, or issues about sexual identity, which maybe if the doctor could talk about with them, that would deal with some aspects of depression or anxiety. So we should make folks aware in a clinical sense what they can do, but I don't see academic detailing as being able to fix those underlying issues, except by bringing greater consciousness to the doctor in as far as that relates to the patient's health status.
Thank you, Jerry, for that honest answer. Melissa, I know you have a lot of experience with looking at those different cross sections of identity and how they impact the kind of care that the VA provides.
Yeah, I think where we've been tackling this is mostly learning from providers about the challenges in really reaching the needs of patients that they feel like they're not able to provide the care that they would like. So I think from a learning perspective, really identifying with the conversations we're able to have and just helping people talk about the challenge and where they see opportunity. I feel like some of these really difficult system problems are often solved by that frontline staff person who has a lot more wisdom and a lot more insight into what would be helpful. So, an example I guess I would have is we were trying to improve our access of naloxone to the homeless population who very rarely show up through our doors. How do we get treatment into an area where we're not getting engagement in care? And there were some great solutions that some of our social workers came up with as far as outreach into some of the homeless care that they were delivering through our homeless programs. And so I think about that as, we have to change healthcare delivery sometimes. We have to reform and transform when we recognize that there are inequities and there are places that we are not designed well to deliver the right care. And so I think that's maybe where I see the partnership of academic detailing is really the opportunity to give the provider a voice in identifying solutions that they see are viable. It may not be them who solves it, right? It may not be that primary care clinician who is the solver of it, but they are often very insightful and give us a lot of opportunity to look at how we can transform to meet the needs of our patients in different areas. So I guess I would say it those conversations are very helpful in having a safe place to talk about it, creating a safe space, creating awareness, and being able to bring that back from a leadership perspective to say, what can we do differently? How can we come at this a different way? And so that's, I guess, what the VA is doing to address that.
Thanks, Melissa. Yeah, and I think understanding that an AD intervention has to be able to pivot, to adapt, is something that maybe we don't talk about as often as we could. I think especially from, a research perspective or an intervention where there are, clear and crisper quantitative measurement goals, it might be hard to then come up against some sort of social or cultural bumps that make it so that the design of the intervention needs to be approached differently or adapted. So I think thinking about some of the things you just talked about, regardless of clinical topic, but really just trying to find a sweet spot between, what Jerry said, what you said, what's realistic for us as folks who are trying to design these interventions. Where are we creeping outside of our ability to save the day and fix all of the awful things that, Jerry and all of us know about, and that do contribute to that level of joy dropping for folks who are trying to combat more than they're able to. How do we find that sweet spot? And also, how do we recognize sort of the power of AD and what it can leverage beyond what we recognize, but also not see it as the magic wand that's going to cure everything? So I really am appreciating the depth and nuance of these conversations. I'm going to check for a few more questions. And in the meantime, I'd love to ask you both to think about how to take this session on home, which I know is my job to lead. But what I would like to say is, with the arc of this conversation and with the expertise you each have and the overlap there, and then the unique spaces in which you've both dwelled around AD, what would you want to kind of leave this big group of folks thinking about as they hopefully relax a little bit for the summer, if that's possible, and maybe either go to or think about going to many of the places that were listed at the beginning of the session? But as they kind of head into the coming months, into the fall, and start thinking about the year beyond that and projects ahead, what would you encourage folks who within AD are also burned out, are also thinking about, how do I maintain my passion when it's so hard to get in the door? How do I feel able to concentrate on the wins and be less despairing of the not yet wins? And what is a realistic way for us to encourage everyone and beyond on this call, without making it seem unrealistic or that it's important to have a perfect, flawless batting average? So some of that stuff is moving through my head so that we can leave folks with a little bit of hope. Jerry, can I throw that to you first? Would you mind taking a stab at that?
Sure, I will start. I think things like what we are doing right now are vital for that, for us to feel like we are part of a larger national and worldwide community that is doing this, and that we can sort of learn from each other and support each other, because it does get lonely out there, especially if it's one individual academic detailer in a room waiting to see a doctor who doesn't always have time to spend as much time as one would like. Sort of knowing that we're all kind of going through this together and that we're part of something that is growing and not shrinking, and telling each other that, and the work that NaRCAD has done in pulling people together has been great in that respect. And also, I can't get over the wisdom of Melissa's points about, this is also about joy and compassion and human relationships. And it is so easy to lose track of that when you're thinking about, visit goals, and did I cover that point, and how many minutes did I spend? That, yeah, we ought to be part of this, what medicine used to be, a much more human endeavor, and that we can support each other in moving back toward that, at least in our own little part of the world.
Thanks, Jerry. Really appreciate that. Melissa, over to you.
I mean, I think Jerry's spot on. The community is so important. That idea that you are seen and that someone cares and that you're not alone, I think is critical to feeling supported in the role of a change agent. The other element to that is sometimes change takes time. And, if you're not seeing the reward of your work, the fruit of your labor, it's hard to stick with it. And I think being able to give detailers feedback, being able to support them, to tell them when things are going well, that type of management investment, I think is critically important. The other thing that we're learning, Mark Buthenvong has been leading some studies on burnout within our organization. We were looking at signals that we've been seeing with our detailers. And one of the things I've been thinking about is, the balance of what work looks like in this field. People who are clinicians practicing, seeing patients every day, also detailing, and how much, when you're wearing multiple hats, how does that attribute to your burnout? Are there other factors that are attributing to that? And really understanding how to design things to support them. I mentioned earlier the importance of play. And our team is really awesome at creating games and gamifying things. And so, whether that's creating a virtual football, virtual detailing competition, doing things where we're creating soccer teams that are playing against one another on programs across the US. I think that idea of how do you create a playful environment, how do you do improv with them, how do you create opportunities for them to feel supported, while also experiencing fun in the workplace. I think we have to design that. We have to be strategic in designing that as part of our organizational investment. And I think if there is play in their heart and their experience, they bring play to the providers. They bring that same energy, that same benefit to the people that they're serving. So it's an investment we need to consider. How do we make it? I'm not saying that everybody's going to have a ping pong table and play like in Google, right? Like that might not be our play environment, but how do we think outside the box and create that opportunity? What does that look like for our workforce? And I think the more creative we can be, the more opportunity we have to really engage people and keep them And retention to me is important. Like, we're talking about relationships here. We're talking about invested time. And I think that turnover is a threat. So if we're not investing in how we keep people engaged in these positions, not only the clinicians we're serving, but the people who are serving those clinicians, I think we're looking at the potential that we're not going to have as effective of an intervention because they're constantly rebuilding relationships. So I do think it's an investment to consider in how we address the burnout issue.
Thank you, Melissa. You know, along with talking about investment in time, I know people are ready to stand up and stretch, but I want to take 30 seconds to thank you both so much for your insights. And one thing I would add on to those great closing thoughts from you both is, you know, how do you, especially for those of you who are one-person teams, how do you create a sense of retaining curiosity, you know, joy in your approach? You know, we're not necessarily trying to beg you to be friends with us, but please be friends with us. Please come to our quarterly check-ins. They're a lot of fun. We're really able to elevate together. Folks often fill out our evals when they leave saying that they feel lighter. So please do check in with us, check out our website. And thank you so much, Melissa and Jerry. This has been a great fireside chat in June. Thank you.
Thank you.
All that said, I am now going to pop back open our slide deck, and I'm going to say happy birthday to academic detailing, which I did not know about, and happy birthday to Jerry. And all of you are welcome to take a break and come on back at 2 p.m. Eastern for your program development workshops. Thanks so much. Please stay connected for now, and then you can switch on over to your workshops. Right. Feel free to shut off your cameras and your mics. Take a breather. Jerry, anything you need to let me know before you disappear? You're still muted. There you go.
Okay, I will be back in place tomorrow for our Invent Your Own Adventure workshop, and we'll be on text if anything comes up between now and then. Text will be the best way to reach me, and I will show up tomorrow. But this is a great session, Bevan. Thank you for pulling it all together, and all the other NaRCADians. It was really great.
Thanks, Jerry. Enjoy the rest of your day.
Thank you.
Bye.
Send us some sunshine.
Okay.
Mike, anything you need at the moment?
No, that was fun.
Okay.
I'm just gonna, you know, get some water and coffee, and yeah, just you know, ping me if there's any housekeeping stuff we need to do. But we're good.
Absolutely will. Anshul, anything you need from me?
Good on my end. Thank you.
Okay, thank you so much. See you in a bit.
Okay, thanks, Anshul. Welcome back from break, everyone. I hope you all enjoyed your workshop sessions. We are going to move into our next session, a special panel on public health detailing for criminal justice involvement. Our presenters are from New York City Department of Health and Mental Hygiene, which I know many of you have turned to for AD guidance in the past, and maybe right now as well. I'm honored to be able to introduce our colleagues Michelle Dresser, Sabrina Parker, and Nina Shabbat. Michelle Dresser is the Senior Manager of Programming and Strategy for the Public Health Detailing Program at the New York City Department of Health and Mental Hygiene. She oversees the overall programmatic direction and strategy of the program, and also oversees internal and external strategic relationships to achieve programmatic objectives. Sabrina Parker is an outreach representative, also known as a detailer, for the Public Health Detailing Program. She promotes preventative health interventions by engaging with healthcare providers, clinical and support staff within hospital systems federally qualified health centers, community health centers, and independent medical offices, as well as community stakeholders to promote health objectives to reduce chronic diseases. And finally, Nina Shabat is the evaluator for the public health detailing program. She leads the planning and execution of all evaluation and monitoring activities for the program, including survey instrument design and internal and external reporting. It is my pleasure to turn it over to Bevan to moderate the first piece of this session with the lovely New York City team.
Thanks, Anna, and hello, everyone who's just joined us, and a particularly warm hello and thank you to the New York City Department of Health and Mental Hygiene, fabulous crew, Michelle, Sabrina, and Nina. We are excited and we are going to dive right in. I'm going to turn the microphone over to Michelle to kick us off. And what we'll do is we'll go through some slides for some level setting. We'll pause and kind of engage with the different sections of what folks are going to be talking about. So Michelle will talk about the campaign itself. Sabrina will talk about what it was like being on the ground detailing, and Nina will, no surprises here, talk about evaluation and assessment. After that point, we'll then be asking you, similar to this morning's fireside chat, to prepare questions, to dive right in and interview these lovely ladies live. So with no further ado, over to you, Michelle.
Great. Thank you so much, Anna and Bevan, and to the rest of the NaRCAD team for inviting us to present on what was considered a groundbreaking campaign for us in the realm of public health detailing, where we had the opportunity to work with providers and staff on what it means for when a patient discloses that they've had a history of criminal justice involvement. So I think, right? We have no disclosures. We can go to the next slide. So as Bevan mentioned, I'm going to talk a little bit about what public health detailing actually means, as most of you are in the realm of academic detailing, and how public health detailing is a little bit different than that work. Why did the agency choose to embark on a criminal justice involvement campaign? What were the materials that were developed to support the implementation of our key recommendations, which is sort of the grounding of our campaigns? As Bevan mentioned, we really want to talk about the implementation, like what were our successes, of course, what were our barriers, and how did we work to try and overcome those, and of course, results. So next slide, please. So really just want to take a moment to talk a little bit about public health detailing. And public health detailing was actually initiated in 2003. And so a little bit of a celebration for us here at the health department, as well as I know academic detailing is celebrating 40 years. We are about to celebrate 20 years of public health detailing here at the New York City Department of Health and Mental Hygiene. And as you can see from this slide, we have had the opportunity to embark on a wide range of topics, working with providers all over New York City and their clinical and non-clinical care teams. And basically what public health detailing does is we work closely primarily with primary care providers and their staff to improve patient care by addressing the leading largely preventable causes of illness, disability, and death. And basically what we've done is drawn on evidence indicating that there are gaps in provider knowledge and the absence of office systems and how to maximize workflows that have contributed to suboptimal care in the healthcare practice setting. And so what we have designed to address these and other cares of delivery. And so we focus on neighborhoods in New York City that have the highest health inequities. And we are trying to reduce the disproportionate burden of poor health. And so our initiatives center really on topics chosen for their anticipated effect on morbidity and mortality and other public health priorities. We have focused, as you can see here from this slide, we have focused on a wide range of conditions, a lot of times focusing on chronic conditions such as hypertension, diabetes, excuse me, diabetes, obesity, medication adherence, smoking cessation, and then topics that are related to clinical prevention and management, such as this campaign that we have been asked to talk about here, the Criminal Justice Involvement Campaign. We are based off of the pharmaceutical sales approach in that we have a team of representatives that go into the office and work with healthcare providers and their staff. So something that's a little bit different for us is that we're not only working with providers in the practice, we do something called the total office call. So we, as I've mentioned, are working with other members of the clinical and non-clinical care teams because we know that they play just as vital of a role in patient care as the providers do. We have, great, yeah, next, that's fine. We'll go to the next slide. So really, why was there a need to conduct a campaign that really addressed what it meant to have a history of criminal justice involvement for patients in New York City? And so through the literature, as you can see here, justice-involved individuals have a higher risk for chronic diseases such as cardiovascular disease, hypertension, and diabetes, and in addition to substance use and mental health conditions. Due to structural racism, people of color are disproportionately bear the burden of criminal justice involvement in New York City. More than 40% of men who are released from state correctional facilities have reported discrimination by healthcare providers, and patients who have been incarcerated may have experienced additional traumas such as long sentences, solitary confinement, with important short and long-term impacts on health. And so because of that, we really understand and want to drive home that every office visit is an opportunity to engage and help patients who disclose a history of criminal justice involvement. Next slide, please. So how do we go about embarking on this campaign? So with every campaign, the first thing that we do is we develop what are known as key recommendations. These are evidence-based or evidence-informed and are really the grounding for each one of our campaigns. It's really the call to action. What are we asking healthcare practices to do? So not only healthcare providers, but everyone within the practice, as I mentioned, can have a role in implementing these key recommendations. Again, as I mentioned, we're an educational outreach program, so all of this is voluntary. So we are coming in trying to partner with our practices on implementing these key recommendations. So for this campaign, we had 4 key recommendations. And we led with, before the key recommendations, that this is if your patient discloses a history of criminal justice involvement. It was very important for us to ground the key recommendations in this, in that that way providers and other members of the care team were prepared if a disclosure happens. And so when that disclosure happens, we want providers and other members of the care team to use non-judgmental language that validates their lived experiences and reassures them of your intention to provide care that reduces the potential health effects of justice involvement. Then we would like them to screen comprehensively for chronic diseases and associated risk factors, infectious diseases, and behavioral health conditions, including substance abuse, because we know that the evidence shows that people that have a history of criminal justice involvement are at higher risk for developing these conditions. Adopt a trauma-informed approach in your clinical and organizational practice. And finally, very important, to connect patients with local behavioral health services and community-based organizations familiar with the social needs of justice involvement, because disclosing a history of criminal justice involvement really brings into play addressing social determinants of health. I know in the fireside chat, there was some questions in the chat about how to address social determinants of health. So this campaign really looks at addressing that as well. Next slide, please.
Michelle. Quick question for you. When you had said that it would be if a patient discloses, does that also include if a clinician asks? And then the disclosure is a response, or is it typically that the disclosure comes by choice of the client, of the patient?
Because of the third key recommendation to adopt a trauma-informed approach, it is best if the patient discloses, so that if there's no bias on the part of the healthcare provider or anyone that's doing like an intake assessment, that maybe asks the question. If it's not asked of everyone in the practice, then it could be deemed as like risk-based or bias-based, that asking about a patient's involvement, if they have any past involvement in the criminal justice system. So it's really preparing providers and staff if that disclosure happens.
Got it. Thank you so much.
Sure. So for all of our campaigns, we have what's called an action kit of materials and resources to support the implementation of the key recommendations into routine clinical practice. So for this, of course, we had the criminal justice action kit. And really, this was a very much a groundbreaking, also a ground softening campaign for this, because a lot of providers were really not necessarily thinking about this on a routine basis. And so the intersectionality between criminal justice context and patient health outcomes, it was a relatively new topic for many providers and such. And as I mentioned, this is really considered a ground softening campaign for us. Also, like justice involvement has downstream impacts on all social determinants of health. And so really, when thinking through the development and the materials were needed for this kit, like what were the themes, what were the needs needed? And first and foremost is we said we had to educate providers and staff on New York State's judicial system. Like other major urban cities, our judicial system is extremely big, complex, robust, nuanced. And so obviously, if you're not a part of that each and every day, it can be a little overwhelming and complicated. And so we knew we needed to work on addressing that. And so we worked very closely with the New York City District Attorney's Office to come up with a piece that I'll show in a second. Secondly, we really wanted to communicate the importance of why it's important when someone discloses a history of criminal justice involvement, like what that means, what you should do, how you should react, how you should communicate, really using plain language, first person, things like that. And we're going to talk about that a little bit later in terms of our successes. As I mentioned before, adopt a trauma-informed care approach. And finally, connect patients with local health and social services, because we know that, again, talking about social determinants of health, patients are coming in having needs that go beyond the clinical spectrum. So really addressing like environmental needs, housing needs, financial needs, social service needs, things of that nature. This is just very briefly to just reiterate what I was talking about in terms of educating on New York City's criminal justice system. So this is really an infographic showing the walkthrough of potentially what could happen to someone as they had involvement in the criminal justice system. We can talk a little bit, we'll talk a little bit more about that later with our successes. This is just one of the pieces of the kit. Again, talking about the need for those linkages for community-based organizations and other services. So we had a piece in here called Your Health Matters, how criminal justice may affect your health. So educating patients also about what it means for their own physical and mental health, as well as some of those resources, providing the evidence to providers and other staff. So we had what was called a city health information, then an epi data brief on why it was important to know if your patient or what to do when a patient discloses a history of criminal justice involvement, and communication strategies. First and foremost, like really employing that trauma based approach, how to communicate, how to partner with your patients when that disclosure happens. I will just point out that where it says Criminal Justice Action Kit at the bottom is hyperlinked. So when you get the slides, that will take you to the entire action kit. But this was just a few pieces to give you sort of that idea or depth and breadth of how we address those key recommendations. And so I am going to turn it over to Sabrina, who's really going to talk about what it was like to be out there and detailing and our successes and sometimes barriers to this campaign. So
Hey, Sabrina, thanks for joining us.
Thank you. Thank you for having us. Thank you, Michelle. So yes, I will say overall, this campaign was a success. We had many providers that thought, was really interesting and that it was a needed campaign. And they expressed that, they were excited that New York City had finally, addressed this particular issue or topic and this population. So that was definitely, a success that you could tell that they were really hungry and they saw it as a problem. And now that there's resources and information and attention being directed to this. So, one of our successes was just providing some knowledge, giving them information that this is what you do, like this is what you can, this is the issue, and that it affects not just that patient itself, that one-on-one patient interaction, but the family and the friends of that group. And then also providing them some comfort as far as like what to do, like how do you now address once someone does disclose. And one of the biggest thing is like, okay, how do I now talk to this patient? So we provide, as you see here, this just some words and phrases that were that you may want to avoid. And this was sort of enlightening to some people because there's some common terms that you would just think is just normal, like conversation, but it could be like considered offensive. And I know for us, like even when we did the training, when we saw the word clean, like, well, why would you want to not use the word clean? That seems like a positive thing. But the flip side of saying someone is clean is just implying that there is some dirty or illicit behavior. So, maybe using a different phrase like the one we offer here is currently abstaining from drug use, making changes to drug use versus saying clean. So just little things like that. And then just shifting the norm, like I said, around using first person language, terms like ex-offender, maybe just say a person who has a history of criminal justice involvement, things like that, that they're non-compliant to versus their medication just not adherent to medication. So like I said, providers were really welcoming. They wanted, excited that they now have resources. But as usual, that's the exciting part and the welcoming part. But then on the other side, a lot of providers were, took offense to us coming in, dealing with these social determinants of health. They felt like, well, are you accusing me now of being a racist? Some of them, shared that they felt insulted, that they felt that they were being attacked. That this was a social issue, that now you're turning into a health issue, and that you're dropping it in my lap. And I'm the last person on the totem pole to actually deal with this. So, we try to just bring some comfort to them, letting them know like, these are resources that you can use for your patients. We all have implicit bias, but we don't want that to interfere with the care that you would offer to your patient. So we provided the resources on what to do when a patient does self-disclose. Some of them say, well, what do I, do? Like this could be opening a can of worms, like, should I put it in the notes or should I, put it in the EHR? And there may be times we told them the patient may say, well, we're not comfortable. I'm not comfortable with you sharing that information in the notes. So what then? What do you do? So, we wanted to make sure that they understand things like the trauma-informed approach. So one of the highlights in that was a lot of the places that we visit, they have literally uniformed security guards standing in a building or facility. That could be triggering to some people, when they see a person in a uniform, like it may evoke a lot of emotions or just behaviors like, okay, why is this person here? Like there's a lot of mistrust. with uniformed and people of power, and just even when you're going to examine a patient or a person and just touching them. You know, I go to my doctor all the time and, you know, her hands are on me. It's like she doesn't really ask, but I'm okay with that. But someone who has a history of criminal justice involvement, you know, that may be triggering to them. So, and these are normal things, like, you know, you would think a doctor has to touch you, a doctor has to, you know, probe some things and ask certain questions. And some of them have said, you know, well, I think the statistics was about 40% of people said that they felt discrimination with the healthcare provider. Like, why are you asking me those questions? Are they targeted questions? What's going to happen to this information? So things like that. You know, we shared with providers that, as Michelle mentioned, we do a total office call, that you do not have to shoulder all of this alone, because as we know in healthcare, you know, they get about 15 minutes with the patient, and that is never enough to deal with all the issues that have to be dealt with, you know. So we, you know, encourage them to sort of go through the workflow, see if there are other people within the organization that can assist, if there's a social worker that can, you know, take on some of this. Definitely utilize them, utilize your medical assistants, your nurses, your educator, your patient educator, patient navigators, patient educators, things like that. And then the last one, because of this, it, you know, took too much time, you know, we sort of thought of ways that, you know, like benefits pieces within the kit that, you know, this kit is actually should be used to actually save time, you know, in the long run. So, you know, definitely think outside of the box how this can sort of like help with that.
All right. Thank you so much, Sabrina, and everyone who is listening and watching. We already have one question. If you have questions for Michelle or Sabrina at this point, don't be shy to put them in the chat box. We'll get back to them, and we'll transition over to Nina, who will talk about the evaluation strategy. Thanks so much, Sabrina, and over to you, Nina. And do we have Nina? Oh, there we are. Hi, Nina. Thanks so much.
Can you hear me?
We can now. Yep.
Okay. Sorry about that. So as my colleagues mentioned, we really did think of this campaign as a ground softening campaign. So we had somewhat different expectations for the types of practice change that we would see and what made sense as an evaluation approach. Typically, when we do our more traditional medical campaigns, we usually ask very kind of specific medical questions about practice, like something like, how often or at what age do you begin screening for X condition, or which patients do you screen for Y condition. But we felt like for this campaign, it really called for a little bit of a different approach, given both the sensitivity and the strong social component. As Sabrina mentioned, you know, people had bring their own experience and reactions to this campaign. So we felt like it made a lot of sense to kind of use a little bit of a softer approach with this campaign, as opposed to asking specifically about clinical practice. So we utilized a Likert type scale instead of open-ended questions, which we would normally ask at both our first initial visit and at follow-up visit, to compare differences in how providers were approaching their clinical practice. And for this campaign, the questions looked something like, on a scale of 1 to 5, with 5 being the highest, how comfortable would you consider yourself in treating patients with a history of criminal justice involvement, or how knowledgeable do you consider yourself about the specific health needs of patients with a CJI exposure, or something to that effect. So next slide, please. So with those questions in mind, we did see a really significant practice change. All of the results here are statistically significant and I think clinically meaningful. We noted that the percentage of providers reporting being moderately to very knowledgeable about the criminal justice system increased from 70% to 87% between the initial and follow-up visit. So that was a period over about 4 to 6 weeks, during which you know, they had time to review the materials, which our detailing reps left behind. the percentage of providers reporting being moderately to very knowledgeable about the specific health needs of patients with a criminal justice history increased from 87% to 96%. And the percentage feeling very comfortable responding to patients who disclosed a history of criminal justice involvement increased from 83% to 91% at the follow-up visit. So those were all really, big improvements in clinical practice that we're really pleased to see. Next slide, please. And then in addition to seeing those changes in comfort and knowledge about the system and how to treat patients with a CJI exposure, we also found some kind of qualitative changes in terms of what types of referrals providers were making. So we did see an increase in the amount of providers that reported they were supporting patients with non-medical issues. We also saw providers that kind of anecdotally reported doing increased screening for food insecurity and housing instability. And they also reported taking additional steps, helping patients deal with challenges related to transitioning back into the community, things like employment or probation and parole demands. Some of that took the form of providers directly providing assistance with, some of the referrals, but in a lot of the practices that we visit, they're a little bit larger or attached to hospitals. So they may have had social workers on site themselves, or like a small social work department that they were able to refer patients to assist in making the referrals for these kinds of resources. So that's just a brief overview of some of the highlights from this campaign.
All right. So that was a quick and compact way of talking about such a groundbreaking campaign, such a new approach to detailing. I'm going to pull out of the deck for a moment so we can see all three of the NYC DOHMH folks, and have all of you have plenty of time to ask some questions. So thank you again for that overview. And what we'll do is start with the first question in the chat box. Don't forget that Anshul has put the public health detailing kits from New York City's team right up on the chat box. Heather Burnett says, how did you involve people with lived experience and or physicians in developing the materials, deciding what was needed in the kit? So who were the people who informed the content of the kit? Michelle, I'll turn that over to you.
Thanks, Bevan. That's a great question. Thanks for that question. So with all of our campaigns, we do a lot of formative research before we embark on a campaign. We have champion providers that we detail with, that we work with them on seeing what are their needs, what are the community's needs, things of that nature. We also work with health literacy consultants to help us with some of this formative research and development. And for every campaign, we assemble a clinical or a content work group to develop these materials and key recommendations. And so we were fortunate at the health department when we started developing this campaign that our current commissioner, Dr. Vasan, was actually at the time the executive director of the criminal justice work that was being done here at the department. So him and his team with us in the public health detailing program collaborated together on the development of this. And then additionally, we're also really fortunate both logistically and like strategically, that we work right down the block from a community organization in New York City called the Fortune Society. And they are the largest community-based organization in New York City that addresses the social, physical and mental health needs of those that were involved in the criminal justice system in New York City. And so they were a huge community partner with us in helping us to develop the materials and the recommendations. And we even went as so far, again, like this was logistically being right down the block is that we went to their office and were able to meet with some of the members of the Fortune Society who utilize the services and ask them, what their experience were, like, what would they be looking for if they were talking to their own doctor about a history of criminal justice involvement. So we were really fortunate to have both internal and external collaborators that were experts in the field of criminal justice involvement on the development of this campaign.
Awesome. Thank you so much.
Yeah.
Mike, I'm going to get to yours just after. Jackie Travers asks this great question. Did the detailers have, or the detailer have existing relationships with the providers? So this is going to be popped over to you, Sabrina. Was there overlap with providers from the stigma work done by New York City in the past? We're thinking about some of the work I believe that Carla Foster was involved with. So was there any overlap there, since there's sort of peripheral and overlapping situations? Sabrina, any thoughts there?
So yes, as far as the relationship that we have, we've established working with providers. So I think we did this in 2019. So we had sort of like a 3-year for myself, like a 3-year working relationship. And, I particularly go back to the same areas, and, just being in New York, you also know the communities as well. So we know what the providers are dealing with. So, the relationship was already established. They, like I said, they were welcoming to the materials that we offer because they knew like this was so needed in the community.
Perfect. Thank you so much. I'm going to pop back up to Mike. Great question here for Sabrina. Sabrina, you described some challenging barriers from the clinicians who had negative reactions, including anger about the intervention and stigma towards people with criminal justice involvement. Would you recommend that programs wanting to do this topic include any specific additional training to prepare for those types of reactions? And also, what strategies and preparation were helpful for you?
So, for our group, we always go through a training, like of content, disease, and whatever. So with this one, it was a little different, social determinants of health, but, we were sort of prepared for the pushback. The first week out, we realized, this was a very different type of campaign. It was very emotional. Like I said, some people were just plain out, insulted. They felt like they were being attacked, that they were being scapegoated. So we recognized that, okay, this is going to be a little different. And for myself, like, our team, we sort of meet people where they are. We have our goals, which were to always improve health outcomes. And we just wanted, providers like, this is not saying that you're racist. This is not saying that, what you're doing is wrong. We always tell them we don't come in to change your practice per se, but we just want you to know the information and the resources that are available to you from the New York City Department of Health, and that this is what the issue is today. Like, these are the stats, this is the issue. So training is always great, like you need to prepare for the pushback. We always go back to the materials, like, we never just drop the ball. So to answer your question, Mike, we always go back to the materials. We utilize, these are the resources that we have. We don't take it personally. We don't push it back on them. Like, you don't have these materials. Like, it's just a material. It's a resource. This is an addendum to what you're already doing. Like I said, we don't come in to change your practice, but it's not a this or that, but it's this and that. So utilize what we offer, incorporate it into your resources, and, sort of help people to sort of get over that issue of, so I'll just say one of the issues was that people felt like, oh, a lot of these groups or this population, they already have resources. They come in, they have social workers that, when they were incarcerated or in prison or jail, like they had the resources. Some did, but many don't. People fall through the cracks, some opportunities are missed, so just making sure that, there's a net of safety, like these materials are there to offer you that net of safety.
Perfect. Thank you so much. And a follow-up question I have for you is, you did say that a lot of the, or some of the providers were really grateful that you brought this to them, that they were glad it was being done. On the whole, would you say reactions were slanted one way more than the other? If you look across, how many visits you made, did you feel that more of them were defensive, or is that kind of hard to say at the moment? And this could be an evaluation question for Nina as well.
So I said it ran the gamut. Like I said, we had providers that were, super excited that we were coming in. We also had providers that were just suspicious, like, why are you doing this? And, I shared with the team, one provider like questioned, okay, so there was a talk of closing Rikers Island, which is one of the jails, here. So that's prime real estate in New York. You close that, what's going to happen to that land? So a lot of providers even felt, okay, this is really where this is going. Like, you guys are putting it in the shell of, closing Rikers and like offering resources and support to people, but what's going to happen to that land? So, people come from different angles, so it was a whole mixed bag of reactions. But, again, our goal to improve health outcomes, making sure that opportunities aren't missed, making sure that providers just don't fall into that trap of just thinking, oh, someone else is going to do it. Like, I don't need to do it, and I wanted to go back to that piece of material that showed them where they actually had a place as far as keeping someone out of prison or jail. When they,
Do you want to see the flow through?
Right.
Would you want me to pull that
If
up?
you
Okay,
could
give me
put
one
that up.
second. All right, let's go on backward. Give me 1 second. Yeah, because that was a really great visual. This one?
Right. Yes. So this alternative to detention piece, there's like two pieces there. That's actually where the provider is. So like, you're a part of this, whether you know it or not, or realized it or not, just making sure that they're aware of that. If a person is mandated to take mental health treatment, or if they do it voluntarily, this is something that can prevent someone from having to spend time in jail. And, in New York City with Rikers, the population, a lot of them sit there because they just can't make bail, so that's, a big issue too. We talked about law enforcement and contact. So this little piece right here, doesn't talk about just being stopped. And, we have this, used to have something called stop and frisk, which technically we no longer do, but it still does happen. And, just even little interactions like that. So maybe you don't actually go to jail or prison, but just some people are sadly just stopped more often than others, and they're constantly. So even providers just have to understand that, and this can affect how a person with their job, with their income, with their education, trying to go to school, things like that. So it's always a bigger layered problem, and this is just what we were just trying to sort of convey to the providers. It's more than just health, but it is health. It goes back into, like I said, with family members. I always remember a case where we had a provider who just could not figure out why a particular woman saw a constant increase in her blood pressure. And it's like, this woman never had blood pressure issues. And after constant probing and probing, she realized, oh, my son just went to prison, and this was this mother taking on this, stress in her life. But sadly, she didn't even see it as stress. The provider was like, you've been dealing with this and you never said anything, so just, it's a mind shift for everyone, for the patient and the provider as well. But it took some probing, from that provider, just constantly like asking. Now let Nina fill in. Sorry, Nina, I'm just taking over.
Some curiosity. Nina, did you want to add anything to that?
No, I mean, I think Sabrina really, did a really excellent job of talking about the wide range of responses. I think that, one of the ways that we always try to kind of be prepared for those barriers in the detailing is just really having a really solid evidence base, so that we can say, look, this is a health issue. Here's why, here's how, these exposures do impact your patient's health, whether you know it or not. Even if the patient may not, have awareness of all of these potential health outcomes that they're at greater risk for, having like a really solid evidence base to build up and arm our detailers, I think is always a really important part of this, of any campaign, but especially in a campaign like this, where you anticipate a little more of that pushback of this is, not in my wheelhouse kind of discussion.
Thank you, Nina. I have a question from Elizabeth Fallybach in Maine. Really great question. And thank you, Elizabeth, for sharing your own implicit bias. She says, before I started working with people in criminal justice, I too had biases. Were there certain aspects of this campaign that were more beneficial in addressing any bias you gleaned from any of this feedback? I would throw that to Sabrina and say, first of all, if we could kind of pivot on that and ask, did you feel like you had any of your own implicit bias going into this? And if so, would you be comfortable sharing any of that and how that manifested and maybe changed over time? And then also, in what ways did you respond to clinician stigma, which I realize is a huge question, but if you could give us an example of a phrase or something like that, or a moment you remember having an exchange with a clinician who may have said something that implied, a significant amount of stigma.
Oh, let's see. So from a personal side, I think dealing with, like, we have a serious homeless population here in New York City. You have people like on the trains and dealing with mental illness. And, I think for myself, it's like when you start to understand the housing issue in New York City, that's when you realize, okay, like this is a big issue. And many of my providers, and this sort of leaned over in two campaigns. We did the depression campaign, but it also was apparent in the criminal justice campaign. A lot of providers said, if New York City could just solve its housing and homeless issue, a lot of these, problems would just not exist. So a lot of people dealing with homelessness, you sort of have this, understanding, oh, they're just lazy, they're just not trying, but it's expensive, to live here in New York City. So, without having a proper home. And then sometimes, again, it's not necessarily like the person per se, but the family. So if you take in New York City, if you take the breadwinner, typically a male of a home, like a household, if he's incarcerated, now what happens to that family? What happens to those children? And the mother, could be trying, to keep the kids in school. But if she loses her home, then they may have to go into a shelter. And then the shelter is typically not in the neighborhood that they were originally living in. And then, but this child still has to go to school. So now you have attendance issues, and it just keeps snowballing into bigger and bigger issues. So yeah, the homelessness issue is a big eye opener in New York City.
Thank you. Thank you. Nina, is there anything you want to add from looking at some of the feedback that may have indicated any trends around stigma?
I think that, an interesting thing to focus on, sort of indirectly related to stigma was sort of the increase in the comfort and knowledge. I think just increasing, especially the knowledge around how the system works and the specific health needs of individuals with CJI exposure can sort of address that bias. I don't think, I think it's obviously a sensitive topic, so providers may have been more or less willing to share any biases that they explicitly had, and of course, very difficult to measure their implicit biases in this type of assessment. So that's not something that I think we were really explicitly looking to measure, but I think helping to increase the knowledge around how the system works and how it touches the number of people that it touches, the kind of like the downstream effects in terms of the family members and all of that, really I think were things that we noted that providers kind of had a little bit of a broader look at and perhaps kind of questioned some of their assumptions when we looked at the data that was available in the follow-up visits.
Thank you, Nina. I have a couple questions from our home team that I've been hanging on to give all you priority, but it looks like we've got some time here. Anna Morgan-Barsamian, our Senior Manager of Training and Education, excuse me. Over to you, Anna. I'd love you to read your question aloud and then add any additional thoughts.
Sure. If you were to do this campaign again, what would you do differently? And that can be around materials development, around the key recommendations or key messages you used, implementation, or the evaluation process. And I'll throw it to you, Michelle, first, to talk about the materials piece and the key recommendations piece.
Sure. Thanks, Anna. That's another great question. So just to give a little context, we actually started developing this campaign in 2018 and launched it in 2019 and concluded it in January of 2020, literally just a couple of months before the pandemic hit. So this is really one of the first opportunities that we've had to be able to talk about the campaign and to promote it and to talk about the evaluation and the outcome. So first and foremost, we're really excited about that. So, you know, having said that, it was 4 or 5 years ago that we developed and implemented the campaign. And obviously we've had a tremendous shift in public health, what that means, how we talk about that. The Board of Health in 2001 declared racism a public health crisis here in New York, and the health department is doing a tremendous amount of work at looking at health inequalities and better bridging that gap between public health and healthcare practices. So that's all to say, yes, even today, we would still think, if we were developing this campaign today, we would still think of it as a ground softening campaign, a groundbreaking campaign, things of that nature. I think our messaging definitely would look a little bit differently. I think we would probably have a little bit more patient messaging. I think we would delve a little bit deeper into social services, although, you know, as Sabrina was mentioning, like, you know, we have a lot of issues, like being one of the largest urban cities in the United States. Like, we have almost 9 million people here. We have a large homelessness problem. There's a huge agenda when it comes to social issues in New York City. And so I'm not sure if I could pinpoint exactly what that differences would be and what the differences look like in the literature. You know, COVID has changed a lot in terms of public health practice, public health messaging. And so I think just generally, yeah, it would look a little bit different. And I think hopefully it would just, it would look similar, but just more. And so, yeah, I'm not sure that's a great answer to your question overall, but yeah, just want to be transparent and truthful about it.
Let's ask kind of and thank you, Michelle, a quick snapshot to follow up on that. Sabrina, is there anything that you would want to do differently, knowing now what you wish you knew then? And then Nina, I'll ask you, is there anything about evaluation or assessment that you wish you had been able to grab in terms of data?
So I know, as Michelle said, you know, I too was sitting here struggling to answer that a little bit because knowing what we've gone through with COVID just magnified the issues that we were already having, you know, to another level. So we definitely need more resources. But the sad thing is that with COVID, a lot of things shut down. So all of the resources that we had in place that we offer to people, we have to now, you know, make sure that they're still operating at the same level. So we definitely need more resources. But I think the paramount thing was that when we declared racism as a health issue, like, that spoke volumes, because it put it in that lens, like, no, it really is a health issue. You know, for myself, coming in, I didn't come from a public health background. So, but one thing I have learned since being here is that everything is a health issue. You know, how you're educated, the food that food access, food insecurities, housing, employment, everything can literally turn into a health issue, like with the social determinants of health. So yeah, shining a lot, making sure people have the resources, the information that they need.
Awesome. That was a really important answer there. And yes, racism as a public health issue. Nina, to wrap us up, if you could have your druthers and all the money and all the research access and all of the assessment tools in the world, what's some data you really wish you had about this campaign? Or if you were to do a similar campaign, would you want to collect?
Yeah, that's a really great question. I think I actually would echo what Michelle and Sabrina said around the importance of the declaration of racism as a public health crisis. I think one thing that we would emphasize maybe a little more in this campaign, if we were to do it again, would be the fact that the criminal justice exposure are not born equally or not spread out equally amongst by race, that people of color are experiencing this in much greater numbers than white people, and that is due to structural racism. And that's a message that the health department has really tried to disseminate very widely around the impact of structural racism on so many aspects of our lives. So I think something that, kind of looking around the knowledge base and how that message was being received, if we were able to communicate that effectively in our messaging, because that's something that would have an impact not only on this campaign, but I think, we see the impacts of structural racism in, all kinds of health problems like chronic disease, diabetes, hypertension. The rates, show that those disparities exist. So I think that would be something that we would really want to look at more closely.
Thank you so much. Thank you, all three of you, for presenting something just so phenomenal that really you all just help us push ourselves to the next level. Those of you in the audience, if you didn't get a chance to ask a question that you're dying to ask, send it on over to us. Any member of our team, and we will pick the brains of these fabulous presenters. Claps and snaps for all three of you. All right. Thank you, Nina. Thank you, Sabrina. And thank you, Michelle. All right. We are ready for our 5-minute wrap up. We are going to speed through, ask you a couple questions, and tell you what is going on tomorrow. Anna, over to you.
All right, we're going to start with 2 chat waterfalls, and then we'll show you the agenda for tomorrow, and we'll give you a little time to do our evaluation while you are still here. So Anjal, over to you for your first chat waterfall.
All right, so we'd love to hear from you all on one new thing you learned today that you were surprised by or excited about. So we'll give you a few moments to think about that, and it could be something from the main sessions or maybe during the program development workshops. I've been starting us off with thinking about the impact of criminal justice help on their families. Love the resources and links to samples. DARN acronym, was that from one of the development sessions? Okay.
Yeah, you'll have to let us know what that means. Oh, gotcha.
Let's see, including a 5-minute presentation as part of an AD job interview, how to apply motivational interviews in an AD visit, another one for the DARN acronym. Love the fireside chat, so many pearls to list.
AD is 40. Yeah. Tactics in working with disinterested providers and hostile providers. Carrie, I'm going to guess that was from our role play session where people secretly asked me to be aggressive. And a few more, Anshul. What are the last 2?
All right, excited about the ways the New York City group and others are bringing a broader lens to what AD can address, returning to the passion of healthcare. Michelle is motivated. And lastly, Amy is saying, I'm looking forward to receiving the list that Bevan and the team has put together from our role play session. That will be available on our website next week.
Yeah, and it'll be available to everyone. So when we had our scene study with 4 different detailers playing against 4 different types of scenarios of a clinician, the audience members in that breakout stole and typed the best phrases they want to use as detailers. And then we compiled them in one big sheet that will be, as Anshul said, on our website for you all to use. And we're calling it steal-worthy phrases. So thank you so much, Anshul, for that chat waterfall. And Anna, you're up next.
All right, this is a fun one. Other than public health, what is something you love? Being outside, flowers, birds, dogs. Okay, I love all those first ones coming in. Ice cream, chocolate, art, reading, football, NaRCAD and cannoli, vacation, skating, basketball and puppies, my family, laughter, trees, coffee and people, traveling, my family, 3 for my family, another one for coffee, Chicago Bears, kids, Zach loves burgers. Particularly McDonald's burgers, right, Zach? And a few
That's
more
only if he has to.
for nature and food and traveling.
Keep them coming as we keep going. They're all great things to look at. Keep filling them up. You can put more than one. So tomorrow, here is what is going on. We're going to have a kickoff, but it's only going to be 5 minutes in length, so we can dive right into this awesome session called the Best Practices Spotlight. All 3 of these presentations will involve Q&A from you all, and they're all about just really cool ways that the patient voice was incorporated into the process of detailing. We're looking at veteran health. We're looking at gender affirming care. We're looking at sex positivity, some really cool stuff that you won't want to miss. We'll have another group of program development workshops, including myself and Jerry, asking you all to choose your own adventure and create a brand new fictional AD program. There'll be a case study about evaluation led by Mike and a colleague of ours named Christopher. We'll also have Anna co-leading real-time design, helping you figure out on a very low budget what compelling visuals look like to bring into your one-to-one visits. And last but not least, breaking the silo, figuring out how to empower clinicians who say, that's not my job, to really understand their connection to the community. We'll take another break, and then we will have, last but not least, an inclusivity roundtable where we ask you, what should you say to clinicians who exhibit through their speech or however else that they may have implicit bias? So helping each other figure out, how do we respond when there are moments where you just frozen and jaw dropped when someone says something. So we're here to empower you there, and then we'll wrap up. The last 2 minutes, we're going to move on over to our evaluation. Anshul, take it away.
All right, thanks, Bevan. I'll pop a link to our evaluation for day 1 in the chat box. We would really love to hear your feedback on how today went, what worked well, rooms for improvement. This is our first time hosting our AD Summit, so we would love any and all feedback that you can provide.
Yes, please be honest. Tell us what worked. Tell us what didn't. And I forgot to mention that tomorrow there is some free reading that Anshul dropped in the chat box. It's of course optional, but for the gender affirming care presentation. So that's up in the chat box. It is also online. Please go ahead and click on the link Anshul just dropped into the chat box and take the last minute or 2 to fill out your eval in real time. The more freshly you do it right after the session, the more accurate it'll be and the more likely it'll get done, which really helps us figure out if this event is working. So with all that in mind, thank you. We'll keep the chat box open for any questions, and have yourself a wonderful evening. Thank you all for being here.
Thank you. See you all tomorrow.